Public health is concerned with protecting and improving the health of populations. To do this, information is needed about the health status of a population and the threats or risks to that group. One of the best ways of getting that information is by surveying members of the community on a variety of health, behavioral, and environmental indicators. Because national data frequently don't reflect what's happening at the local level, the most useful information often comes from local assessments of health. Minnesota is fortunate in having a variety of state and local surveys that help us determine the public health issues that are having the greatest impact on the health of Minnesotans. One of the oldest and most influential local surveys is the SHAPE survey, which comes out of Hennepin County. We'll be talking about this survey and reviewing some of its findings on today's episode of A Public Health Journal. Please stay tuned.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to talk about assessing the health of our communities and the people who live there, and how the information gained in that assessment can be used to protect and improve the health of the community. In particular, we'll be looking at a comprehensive health survey done by the Hennepin County Department of Public Health. It's called the SHAPE survey, which stands for the Survey of All the Population and the Environment. This is a survey which collects a broad array of health information from a sample of Hennepin County residents every 4 years. Joining us in our discussion today is Dave Johnson, Program Manager for the Health Statistics and Surveillance Program for the Hennepin County Public Health Department. It's the program that oversees the SHAPE program. Dave, welcome to our program.
Thanks.
So this is, I've had people on, this is the first time you've been on talking about SHAPE, but SHAPE has been going on for a long time. So let's just get some background. What is the SHAPE survey?
The SHAPE survey is a population-based health survey, and what we're trying to do with the project is to describe the health of the population so that we know trends in health status. We can look at populations that are affected differently, and it's modeled after some national surveys that are done by the Centers for Disease Control and Prevention, like the Behavioral Risk Factor Surveillance Survey. We want local data that help us compare to those surveys, and then also provide more information about our population that we can't get from those national type surveys.
So how long has this survey been done?
We've been doing the SHAPE survey every 4 years since 1998.
Okay, and you focus just on Hennepin County, is that correct?
In the beginning, that's true. The survey started out in 1998 with an adult health survey. And every 4 years that we've done the project, we've looked to improve the project over time. And so some of the changes that have taken place over time are, in 2006, we added a child component whereby we asked parents to answer questions about the health of their children so that we could get a fuller picture of the health of the population. More recently, in the latest iteration of the SHAPE survey, which was done in 2014, we actually combined two survey efforts that had been taking place across the Twin Cities metro. And so in addition to the SHAPE survey, there was also a metro survey called the Metro Adult Health Survey that was done by other local public health departments. In 2014, we decided, because there were these two separate efforts going on, we should combine them together in order to increase our reach, to have a common instrument, and to be able to compare across the entire Twin Cities metro.
Oh, so the data collected with the SHAPE survey may not have been called SHAPE in other parts of the metro area, so you have a broader sample of which you can compare Hennepin County to other jurisdictions?
Exactly. Now, because we're using the same survey instrument, we can look at results across the metro. We can compare amongst the different counties, and then overall we have a larger pool of information to draw from now going forward.
So this is a sample. Not everybody gets this survey. It's a sample. How do you sample in Hennepin County?
Exactly. The goal of the survey is to describe the health of the population overall, and it would be very, very expensive to ask every single person in the county about their health. So what we do is we draw a randomized sample so that we can generalize to the population, because we're doing it at random. When the SHAPE survey started in 1998, we could use landline phone-based sampling in order to do this Since then, obviously, the landscape has changed very dramatically. Landline phone use is going down and down precipitously. People are using cell phones now more and more. There's people living in our communities who have area codes that aren't even associated with the Twin Cities anymore. And so it's very, very difficult and expensive to use phone sampling. What we've done more recently is we've switched to a mail-based sampling. So we randomly select households across the county, and we mailed them an invitation to complete the survey.
Do you oversample? I mean, any population groups or any neighborhoods or anything like that to, where you might get a lower response, or where you have a small number of folks that you really want to know more about?
Exactly. That's a very important aspect of the survey. We know that we want to be able to describe the health of our population as completely as possible, and we also know that some groups are less likely to respond to surveys. Low-income populations and populations of color, communities of color, are less likely to respond to surveys. And that's something that's true nationwide across survey efforts. And so what we did is we looked at US Census data to find those types of communities within our sample area, and we mailed more surveys. We oversampled those areas, so a higher proportion of the households got selected from those areas to participate in the survey.
And I assume language is an issue that you have to deal with. Do you have translations available for these surveys?
Yes, we had a language card that went out with the survey. It was translated into 10 different languages and provided phone-based interpretation for individuals. Unfortunately, I would say that that service was underutilized, and so it's important for us to be upfront about some of the limitations of the data. And so one of the limitations is that we're not fully able to describe the health of populations who don't speak English with this survey. And that's a real limitation, but we look to other sources of information to help fill in those data gaps that we have.
So how has the survey been used over the years that you've been doing it?
The survey has very broad use. We define health very broadly. We want to be very holistic in our definition. So we do ask about things like chronic health conditions. Does someone have diabetes? Do they have heart disease? How is their overall health? But we also want to bring in aspects of their mental health as well, because we know that mental health is so connected to physical health. We also ask about people's social and neighborhood environments that they live in, because we know that opportunities for health are governed by where we live, the places where we live, the opportunities that we have in our communities. And so we ask people about, for example, their access to walking trails, how well they can get along with neighbors, what their social connections are like, and things that we know that are important for their health.
Who gets to use the survey? Who do you share the data with?
Yeah. So we share the data very broadly. We have a website where we make the data available. But we use it in public health, we use it for planning purposes, but we also share it with community groups that are interested in improving the health of their communities. And so it helps provide those individuals with some information about what health issues exist in their community, and can help them do things, for example, like to write a grant to help get money into their community to work on a particular issue, because they can show that there are differences in their community and they can demonstrate the need for services in their community.
Right. Well, I want to get into some of the actual data, but first we're going to take a little break. So we'll be back right after this comment.
I'm Clarence Jones from Southside Community Health Services in South Minneapolis. This summer, Twin City residents will be randomly chosen to participate in the Metro Shape Health Survey. In this short 20-minute questionnaire, participants will be asked about the types of food that they eat, how much exercise they get, and other health-related topics. If you should receive an invitation to take the survey, I strongly encourage you to complete it. Your answers and those of other Twin City residents will help identify the unique health needs of our community. They will allow us to better plan a healthier future for us and for future generations. Your answers will be anonymous and your information kept secure. Your health matters, your answers matter, and I thank you for participating.
Welcome back. We're talking about the SHAPE survey with Dave Johnson from the Hennepin County Public Health Department. Dave, it looks like that was one of the sort of promotional things that you did for the getting the survey out. Tell us a little bit about that public service announcement.
Sure. We recruited people from the community to help get the word out about the survey. One of the interesting things that we did this time around for the first time is we had a web-based response option. For people who didn't have computers, we did also offer a paper version of the survey, but we know that lots of people have online access. Online access is going up. And so we produced some videos to accompany our website that help give people a little background about the survey. We did those videos in different languages so that people could hear a little bit about the survey in their own language, and then just kind of tried to get the word out about the survey as well.
Okay. Well, let's get into some of the actual data itself. And we've got a slide here that really looks at the people who are reporting fair or poor health. And we're going to have several slides with this format. So could you explain sort of the format of this so that people can understand
Sure.
what they're looking at?
Sure, and so this is a typical reporting slide that we use for looking at our data. The slide that we're looking at here is the percentage of people who report poor or fair health. And this is a really interesting question. It's a survey question that's used very frequently in research. It's just, how would you rate your overall health? Excellent, very good, good, fair, or poor. And it sounds like a very simple question, but the interesting thing is that it's very highly correlated across a number of different health factors. And so we use it as a general sentinel question to look at differences in the population's health. And so when we look at the slide, we've broken down answers to this question by income and by education, because we know that health status is very closely associated with someone's socioeconomic status. And when we look at our results for this question, we can really see that in great detail. And so in the green bars, we are looking at the association between income and health. And we can see that for people earning $23,000 or less, almost a third of them, 29%, say that their health is fair or poor, compared with households earning $55,000 or more. Only 3.4% of those households reported poor or fair health.
So income makes a huge difference in terms of how well you feel.
It's massive. That's almost a tenfold difference.
Right.
And so that's one of the disparities that we are really trying to show with this information.
And similarly with education, again, often correlates with income, but the lower your education level, the fewer healthy days you have each month.
Exactly, exactly. And so we also see that same by someone's educational attainment. And so this is really helping us understand the way that someone's health is linked with their socioeconomic status.
Right. So how has this been going? You've done this for now many, many years, since 1998. How is this trend? Are we getting more days, healthy days, or are we going down, getting better or worse?
Actually, with this survey, with this question, we're looking about the same. Things haven't changed a whole lot with poor or fair health. A little over 7% of people overall say that their health is fair or poor. This is down a little bit from more recent iterations of the survey, but there hasn't been a whole lot of change over time.
And one of the things we're always looking at, we know that we're an increasingly diverse society. Are there racial differences in terms of how healthy people feel?
Yes, there definitely are. Particularly when we look at the health among U.S.-born Black and African Americans, there's a several-fold difference between the percentage of people who are reporting poor or fair health. And so we know that race also makes a big difference.
All right. And I know one of the issues that really has come up frequently is sort of the mental health status of folks. And I know that you've added that component to this survey. And so we've got a slide here that looks at the people who've experienced frequent mental distress. And we have a similar kind of slide that we had before. Tell us a little bit about what you're finding here with how you define that mental distress and the findings that we have.
Mm-hmm. Frequent mental distress is looking at individuals who are experiencing poor mental health on many days in a month. And so when we look at that, again, we see some similar concerns by income and educational attainment. We see that people who have low income, more than 1 in 5 of our respondents reported that they experience frequent mental distress, compared with only about 5% of those in households with an income of $55,000 or more a year. And so, again, we're seeing that there's big differences in physical health. We're also seeing big differences in mental health.
So in terms of asking the questions about the environment and the social factors that they're dealing with, has your data pointed out some reasons why that might be? That why people with lower income or lower educational level have more mental distress?
Yeah, I think there's a number of factors that play into that. Obviously, people with lower access to resources have a harder time accessing care. And I think that we have seen that access to care overall is improving with the Affordable Care Act and things. More people have health insurance, but there's still issues with people being able to access care. People are reporting, with lower incomes, report more, they have a higher chance of delaying or not receiving physical care for physical and mental health. And then when they do seek care, they also report more trouble with paying for that care.
Mm-hmm. Did you ask about things like housing, the stability of their housing, access to food? You know, if they were food insecure, would that also be part of the, leading to the stress if they have less stable housing and poor access to food or are living in unsafe neighborhoods?
Right, exactly. So we looked at all those things. We asked if people had trouble making mortgage or rent payments. We asked if they worried about running out of food before they had money to buy more. And so obviously people who had less income reported higher levels of stress in terms of their housing and in terms of their food security.
All right. Now we want to have some questions related to obesity and physical activity. And so we want to get at those, but we'll do that in the next segment. So we need to take a little break. We'll be back right after this message.
So you see, son, good manners are important. Should I go through it again?
Yes.
Yes, please.
Yes, please.
Exactly. Always say please, thank you, you're welcome, excuse me, sit up straight, hold doors open for ladies. If the door's locked, knock first. Don't burp, don't swear, don't stare, don't use bad language, or talk with your mouth full. Keep your elbows off the table.
What table?
And don't interrupt. Cover your mouth when you cough or sneeze. On the bus, give your seat up to anybody who has trouble standing. Bottom line, treat others the way you want to be treated. Got it?
Got it.
Good talk.
Most parenting is hard to do in just 2 minutes. But 2 minutes twice a day making sure they brush is easier, and it could help save them from a lifetime of tooth pain.
Welcome back. We're talking with Dave Johnson from the Hennepin County Public Health Department about the SHAPE survey, the study of health in Hennepin County and Minneapolis. Dave, do you look at differences between Minneapolis and suburban Hennepin County in some of these studies? Because I assume Minneapolis and the Minneapolis Health Department would really be interested in what's going on with their population.
Yes. Since SHAPE was first started, we have been interested in looking at community level differences in health status because, again, like we were talking about before, place does matter. Where you live has an impact on your health. And so we now report on 10 different geographies within Hennepin County. As I mentioned as well, we also have the ability to look at data for other Twin City metro counties. And in Ramsey County, we looked at differences between people living in the city of St. Paul versus suburban Ramsey County. And we definitely see differences in health status.
I can imagine. All right. Well, we've got two other slides that I want to go through just because it's important. And one of them is the percent being obese by income and education. And you see a similar kind of pattern. So tell us a little bit about how you defined that obesity. You didn't weigh people, but was it just their description of themselves?
So obesity is measured by asking someone their height and their weight. This is a question where we know that there's some reporting bias. Obviously, we all like to probably maybe overestimate our height, maybe underestimate our weight. And so we know that the differences here are at least as bad as people are reporting. They're probably even a little worse than this based on some of the reporting bias. But there's some standard measurements whereby we compare someone's height to their weight. That leads to a body mass index calculation. People who have a body mass index of 30 and above are considered obese. And so one of the things that we're obviously very interested in is obesity's connection with a lot of different physical health problems, heart disease, diabetes, cancer. And so we've been tracking this indicator closely over time. One of the things we've noticed is that we've had an upward trend in obesity. Recently, we've been looking at some national data that had showed a bending of the curve and that the trend might be slowing. More recent data has actually shown that we're still not over that hump yet. And in our current survey, we found that about 21% of people overall reported being obese.
Yeah. Now, if you look at this slide, I notice there's still that link between education and income and obesity, but it doesn't seem as dramatic as the other ones in terms of mental health or overall general health. It looks like even, yes, there are still disparities, but the disparities aren't as great. That means that everybody's getting a little bit fatter.
Yeah, it's definitely something that impacts our entire population. We do see some of those same differences by income and education, but it's something that we need to be concerned about at a population level as well.
And always related to that is the physical activity. And then the last slide we have is really looking at leisure time or lack of leisure time physical activity, again, by income and education. And you see some of the same patterns that we had in other ones, but again, you know, not quite as dramatic as some of the others.
Right, yes, I'd agree. I think it's important to point out, these are people who are reporting that they're getting absolutely no leisure time physical activity. So it's quite concerning. And then when we unpack that data and look at it, we find that almost 1 in 3 low-income individuals are reporting that they are not receiving any leisure physical time activity. And so that's obviously concerning because we know that that's linked to obesity. You know, we know that there's lots of barriers that people who are in low-income situations might be experiencing that can have a huge impact on that. You know, for example, they also reported having less safety in their neighborhood, so it might be harder for them to get out and go for a walk. They also may have multiple jobs where they're more time crunched than people who have higher incomes. And so there's a lot of factors that we need to be looking at that are important for people and being able to be physically active.
How has the trend been? You know, you talked about the obesity trend. How about the physical activity trend?
It's been relatively flat. Again, it's something that we want to continue to encourage, but it's something where we haven't seen a lot of change over time in this one either.
And I assume that there'd be we know that, you know, physical activity sometimes relate to the opportunities. If you have trails in your community, or if you have access to parks, people get out more. Those kinds of comparisons, have you been able to see that the sort of the public infrastructure for physical activity, does that make a difference in the amount of effort that, or time that people exercise?
Yeah, so we did ask about people's access to walking trails, hiking trails in their community, and that did show that people who had more access got more physical activity. And so we know that we need to be looking at people's physical environments.
Mm-hmm. Also, as I looked through all of the charts and graphs, you know, there really were some huge disparities related to race and ethnicity.
Mm-hmm.
Did you find that in pretty much all of the factors that you looked at?
Yeah, we did. And it's something that we've seen over time, and we want to continue to unpack that type of information with the community to help us understand what that means. Again, like I mentioned before, we're missing some communities in terms of representation in this survey, and so we'll need to look to other ways to get at, for example, communities that don't speak English. We think that there may be differences there as well. But an example of a unique perspective that our survey can bring to some of the issues about race and health is that we do ask a novel question about discrimination experience. And we do see that particularly African Americans report higher levels of discrimination. And for people who experience more discrimination, we see some very clear ties to health status, to ability to access medical care. And so we need to unpack this data with communities to help us understand what it means and to help us encourage the health of all our residents.
Did anything jump out at you in your survey? Anything that said, oh my goodness, we need to do something about this?
You know, I think what it really did is it affirmed some of the things that we know about health. You know, the problems of obesity, smoking haven't gone away. You know, one of the things that we're looking at with smoking, our survey showed that we are turning the curve with that particular health issue. Smoking rates have gone down over time. But when we looked at the data in more detail and looked at among low-income individuals living in multi-unit housing high-rises, those individuals had a rate of smoking that was above 20%. And so, again, I think it's in the details where we need to be focusing. And this survey is really the only opportunity that we have to look at some of those detailed pieces of information that can help us get to the root causes of our health issues.
So have you shared these data with the county board? I assume that they're really interested in what's going on in their county.
Yeah, we're just now starting to release the data, and so we're going to be sharing it with our policymakers, within our staff at Hennepin County, but then also working with community groups to bring the data out to different communities, and to have important discussions about what the data tell us, whether the data feel valid to them, what might we be missing at the same time. And I think in that, it's important that the data are a starting point for that discussion. They help us say, here's what we think we know, what else can you tell us about this data?
All right, well, I'm glad that we can help you get out the information, that the data are now available. Dave, this has been really helpful. Thank you very much for being on the show.
Thank you.
All right, I'll be back with a closing comment right after this message.
It's not that hard.
My big man fingers are having a problem with these little tiny buttons.
Whoa, watch it there. Your blood pressure's gonna go through the roof.
Tell me about it. I'm trying to learn how to get it down. Instead, it keeps going up.
High blood pressure can increase the risk for heart attack or stroke. Learn how to keep yours at a healthy range.
Ever hear a voice command? Just say text barbershop to 97779.
That's not what I said.
Just give me that. Now my blood pressure's up.
There's an old aphorism that says, if you look for trouble, you will find it. When our parents spoke those words, they were telling us to do our best to stay out of trouble. However, in public health lingo, this is a statement of purpose. It highlights the fact that one of the main jobs of public health is to look for and find trouble. That's why the assessment function or the data collection activities of public health are so important. But simply identifying problems or trouble is not enough. That's why public health adds this aphorism to your parents' old saw. What gets measured gets done. While this might be a bit of an overstatement, it does point out the importance of the link between data and action. If you don't have a way to measure a problem, you'll never know the real magnitude of the problem or how high of a priority it should be. Also, if you don't quantify the existence or the extent of a problem, you'll never really be able to determine whether or not you are being successful in eliminating it. That's why data collection is so crucial to the functioning of public health. And it's important at all levels of public health, national, state, and local. U.S. Representative Tip O'Neill once said, all politics is local. While not all public health is local, a great deal of it is. That's why if we are going to have healthy communities, our local public health agencies must have the capacity to assess the health needs of their community and the ability to respond to what they find. Since what gets measured gets done, public health at all levels should prove our parents right. If you look for trouble, you will find it. That's all for today. Thanks for watching. I hope you can join us again next time on a Public Health Journal.